I'd like to invite Gil Melmed back to the stage, and we'll take some questions before we go to break. And we have two microphones up there, so Gareth Dulay will kick us off.
So much. That's a great way to start the conference. Just one general comment before a question. I see a lot of people taking pictures, which is fine, but if you feel like you missed something, all these slides will be available thanks to our presenters on our website. So you can go look at them at your leisure, just enjoy it now, take it in, and please come up and ask questions. So mine is about JAK inhibitors and the issue, obviously, of thromboembolic events and discussing it with a worried patient who you think might be a good candidate. And I guess whether you think it's ever worth it, or do you ever offer testing for common known thrombophilic disorders like factor V von Leyden or antiphospholipid antibody syndrome? Would you ever use that, especially if there's at least some preliminary evidence that maybe if those people are identified and put on an anticoagulant, perhaps you have better outcomes?
Sure, I'm happy to take that one. That's an excellent question. And I will say, I think it is going to lead to a point where they will drop that for IBD, but for any patient who has any concern or a family history or there's some potential for that, I am very much in favor of involving our hematology, oncology colleagues and just getting them a thorough assessment, because at the end of the day, we will all sleep better for it. But I think the likelihood may be still fairly low of them either having it and or developing a VT. So I think if there is still some push and pull and this is the right treatment for the patient and it cannot wait, I would advocate for it. I don't know, what do you think, Gil?
So I would tend to I don't test for thrombotic conditions or predisposition in patients. It's never actually come up in conversation. I think what's really helpful is explaining to the patient, where does this warning even come from? Oh, well, it comes from another disease state. It comes from a trial done in rheumatoid arthritis, not in IBD. Oh, and people in that trial were all over the age of 50, and assuming that's the case, but you're not. Oh, and the people in that study also had at least one cardiovascular risk factor, and you don't. So I think framing it in that way, those three things, RA, over the age of 50, with at least one cardiovascular risk factor. That was the study upon which the FDA based its warning for increased risk in JAK inhibitors, because there was a higher rate of thrombotic events in the patients treated with JAK inhibitors compared to TNFs. And if there are risk factors, then I think some of the data that Niru talked about is really helpful to think about. There is no actual increased risk of MACE events. Perhaps if you truly have a known higher risk, that might be a situation for anticoagulation, but that's a very, very unusual situation. So I don't ever have that. That's never come up for me for testing, but I also think that there's risk to testing. Where there's the likelihood of a false positive, of a false negative, and the roads that can lead down. So I don't know that would be something I would encourage.
Great, thank you. Kelvin?
Right. Thanks for your fantastic talk. So the first question actually for Dr. Melmed. With the data that you just presented, did you run into situations that you had to switch from ustekinumab to risankizumab? Especially if patients have a partial response. And the second question for Dr. Bonthala, telling my Asian patient to switch to a Mediterranean diet is tough. So usually I say, cut down on your red meat, try to go to plant-based diet. Anything else you might add to specific populations when it comes to diet? Thanks.
So I didn't really talk about ustekinumab failures going to risankizumab or another 23 inhibitor, but there is data that patients exposed to ustekinumab were included in the RISA trials, capped at a certain percentage, and they seem to respond similarly to the rest of the population that were ustekinumab naive. So from my standpoint, I treat them differently, even though they're similar. I would offer risankizumab or another 23 inhibitor to a patient who has previously been exposed to ustekinumab.
And regarding personalization of diet across cultures, this is a great question. And I think some of the principles of the Mediterranean diet are fairly universal. So some of them are have to do with trying to avoid processed food. So I think if you can say very, sort of avoiding processed food, eating things as they're meant to be eaten as a whole, and trying to, sort of eat just cleanly. I think those are all basic principles of the Mediterranean diet that are pretty universally applicable.
Can I just throw in a quick anecdote? We had a diet course, and we had a speaker from Portugal. And so for him, the Mediterranean diet is just diet. Right. So and then so what do they do, right? So I mean, some of them are going to McDonald's every day, of course, in Portugal too. But I think that we do need to be sensitive to where people are coming from, and I think the principles, as Nira outlined, are appropriate and there are ways to tailor them to. We should be thinking about ways to tailor them to wherever people are coming from.
Great. We're going to go to the back microphone first.
Thank you so much. Just a quick question about JAK inhibitors and oral contraceptives. I mean, the focus has been on birth control. What about our young patients who are on oral contraceptives for other reasons who may be candidates for JAK inhibitors? What's your approach to that? Anticoagulants, not, avoid, don't worry about it?
Yeah, that's an excellent question. So we're actually looking at it from a research perspective from the menopause program, where we have this pathway for some of our patients who are on JAKs that we're looking at and their cardiovascular risk, having them see actually one of the cardiologists and really flushing this out. So more to come in the upcoming years on that. But the main thing I would say is that they're on it, oral contraceptives, et cetera, for other reasons, and whether it's endometriosis and whatnot, there are ways to decrease the amount of estrogen to either a low estrogen type of compound or progestin only, which also tends to have some beneficial endometriosis overlap. So I try to favor those if possible for it, or sometimes they can use other methods like spironolactone, et cetera, to help with some of these other insulin resistance. So there are ways to creatively do it, but I would say it probably would be best done in conjunction with a certified contraceptive specific person in mind. And then as far as with JAKs, I don't have a huge, for patients who are otherwise low risk, I don't have a huge issue with JAKs and the low estrogens or the progestin only ones. The ones who are on full dose like estrogen, whether it's for hormone replacement or whatnot, then I do worry a bit more with it, and I try to get them to a lower JAK if possible, or sometimes, as we're using JAKs now as sort of induction agents, to pass them on to something else that's a little bit safer, then that might be a more appropriate scenario for them.
Excellent, thank you.
Great. And then one last question we'll take.
It's more of a comment, where you're talking about factors that people and I adjust. And I laugh because a few years ago, a patient showed up in my office, and she says, "This is something you might be interested in." It was a handout from Beryl Crone to her mother. And in it was, he told them to avoid anything with competition, especially sports. He encouraged them to go on long walks. And his dietary recommendations are really similar to the Mediterranean diet. So once again, we're back to the beginning.
That's perfect. That's a great note to end on. Thank you very much, Dr. Melmed, Dr. Bonthala.